Alright guys, let's get busy talking about disorders of genital embryology. We're going to be building off a lot of our previous video on sexual differentiation, so you should go ahead and give that one a watch because it has a lot of building block material that applies to this video and it's going to be really helpful. So let's go ahead and get started by talking about our male disorders of development. We're going to start off by talking about epispadias. So let's go ahead and take a look at my picture here of our developing genitals in their undifferentiated form, as well as my rudimentary drawing of a penis here. You'll see that we have our shaft and we have our glans penis here, and then we have our scrotum, and then this pink line represents our urethra, which is responsible for delivering urine and semen outside of the body. So if we take a look here at epispadias, it's going to be due to faulty positioning of the genital tubercle. And you'll remember in our previous video, we highlighted our genital tubercle in red, and it is responsible for forming this area of the penis near the glans. Now, what happens in epispadias is that this structure is going to be located too far posterior, and it's going to kind of branch out dorsally. So we're going to kind of get a line here like I'm drawing, just like this. And what's going to happen is we're going to have this abnormal connection where our urethra is going to come out, and it's going to come out posteriorly, and it's going to come out on the dorsal side of the penis. So to refresh your anatomy, dorsal side is going to be here and ventral side is going to be here. And so in epispadias, we're going to get our urethra coming out, and people are going to be peeing outside of the top of their penis. And so this can be corrected surgically, but importantly, we need to know that it has some associations on step 1. And that's going to be the association with bladder atrophy as well as urinary incontinence. And it makes sense if you have urinary incontinence if your urethra is coming out of the top of your penis. But let's go ahead and talk about another pathology that is really related to epispadias, and it's going to be called hypospadias. And hypospadias is going to be due to failure of the urogenital fold to close. So in our developing penis, our urogenital fold is like around this area here, and it's responsible for like zipping up along the midline. So it should zip up along here, along this bottom ventral portion of our penis, and it's responsible for closing that portion of the urethra. Now, what happens when this doesn't zip up properly is we get an abnormal connection here along the bottom side of the penis. This is the ventral side. And so we're going to have abnormal connection here, and our urine is going to come out of the bottom of the penis. And this is also going to lead to urinary incontinence. And there's also some high yield associations to know on step 1, and that's going to be that it's associated with inguinal hernias as well as cryptorchidism. And remember that this is going to be an opening on the ventral side, whereas in epispadias we had an opening on our dorsal side. Let's move on to talk about cryptorchidism, since it is a risk factor from hypospadias. So I'm going to draw in some imaginary testicles back here on our developing embryo. And remember, I like to highlight mesoderm in pink, which is what testicles come from. They come from intermediate mesoderm from the mesonephros. And what we're going to have here in our testicles is that they are a retroperitoneal structure. So they develop in the retroperitoneum, and they're going to migrate into what is going to become the scrotum. And so their job is to migrate down, and we expect that those testes have migrated down into the scrotum by age 6 months. Now, when the testes fail to descend into the scrotum, that's when we call this cryptorchidism, and that's testes failure to descend. And this is problematic because it can cause some complications for our patients. 2 of those complications, which are high yields on the step 1 exam, are going to be number 1, cancer. So when we have cryptorchidism, we can get cancer because our testes are essentially squashed in a location where they're not supposed to be, and this can lead to testicular cancer. The other reason why we want to avoid cryptorchidism is because it can cause infertility. And this infertility is going to occur because when our testicles are not in our scrotum, they reach really high temperatures. The reason why humans have a scrotum is because it allows the testicles to be cool, and the Leydig and Sertoli cells are very temperature sensitive. So if they are still up in the retroperitoneum where it's really hot and bothersome up there, those Sertoli cells, those Leydig cells are not going to be happy, and it's going to lead to infertility in our patients. So if we do have a patient who has not had their testicles descend after 6 months, we can perform an operation called an orchiopexy, and this is when we manually take the testicles and move them down into the scrotum for the patient so we can avoid these 2 complications. Let's move on now to talk about Müllerian agenesis. So Müllerian agenesis is just like it sounds. You'll remember we talked about our Müllerian ducts, also called the paramesonephric ducts. And Müllerian agenesis is just failure of these to form in a patient who has two X chromosomes. So we're going to have failure of our Müllerian ducts to develop, and this is going to present with a specific constellation of symptoms. So we're going to see primary amenorrhea, which means that they have failure to produce a period or have a menstrual cycle. However, we are also going to have normal development of breasts as well as the external genitalia and body hair. And so let's look at this developmental wise at the embryology here and explain this. So if we have lack of paramesonephric ducts, we're going to be missing our oviduct, which is also called fallopian tube, as well as our uterus and our upper vagina. So we need a uterus in order to have a menstrual cycle, because the menstrual cycle is the shedding of the uterine lining every month. And so if we don't have a uterus, it's impossible to have a menstrual cycle. And so we're going to have primary amenorrhea because we are not going to be able to have a menstrual cycle without a uterus. Now, why is it that we have normal development of our breasts and external genitalia as well as body hair? Well, the thing is here, these patients still have ovaries, and you'll remember it's our ovaries that are responsible for creating the chemicals that lead to the female phenotype. So this is going to be things like androgens, which are going to be responsible for making things like body hair, as well as estrogen, which we talked about was responsible for external genitalia development in our previous video. And as well, breasts are due to estrogen as well. So if we have estrogen, we're going to have breast development at the proper time. The structures that are going to be absent here are all the ones that come from the Müllerian duct. So on exam, we're going to have an absent uterus, an absent upper vagina, and an absent oviduct or fallopian tubes. However, our ovaries will be present and they will be functional, which explains why we got all the other structures that I just talked about. Next, let's talk about a few pathologies of the uterus. We'll start by talking about a bicornuate uterus, and this is when we have incomplete paramesonephric duct fusion. So normally our paramesonephric ducts are going to come together to create a single uterus. However, if you look at the imaging below here, you'll see that we have two distinct uterine horns here. So our paramesonephric ducts were supposed to come together here and form one distinct uterus. However, they did not do that here in this example. And this is what a bicornuate uterus would look like on imaging when we fill that cavity with some sort of dye that is going to show up on imaging. And then we have another pathology that is going to be called a septate uterus. And so this is when we have proper joining of the paramesonephric ducts. So they're going to join together. However, we have this septum of tissue that is here in the middle, and this is going to cause problems for the patient when it comes to reproductive capacity as well as having normal menstrual cycles. And this is all due to the incomplete resorption of that red septum that I just drew. One more pathology that I want to mention is going to be DES exposure, and this is going to be specific to babies in utero. So this is going to affect female children in utero whose mothers are taking DES, and DES is a drug that is going to lead to vaginal adenocarcinoma in the future for that fetus, as well as a T-shaped uterus and abnormal fimbriae, so their fallopian tubes are not going to be able to scoop up that egg appropriately, so these patients are going to deal with infertility. And for this reason, we don't give DES to pregnant mothers anymore, because we're going to lead to these types of effects in their female fetuses. I want to wrap up with some brief summary and talk about how these things are going to present on test day. So remember, epispadias is going to be all about this dorsal side of the penis, whereas in hypospadias, it's going to be in the ventral side of the penis. And a patient with hypospadias will classically be described as like a younger male who's having difficulty going to the bathroom. Maybe he's splashing when he tries to make pee, and that's because his urethra is coming out of the bottom side of his penis. And then the follow-up third order part of the question will be, after surgical repair, what is something that we have to also be aware of in terms of this patient? And the answer here would be inguinal hernias and cryptorchidism. So it would be doing a proper inguinal exam on this patient to make sure that they're not at risk for those types of things, which could lead to infertility or cancer. On the female side, we talked about Müllerian agenesis, and this is all about knowing your basic embryology, which we talked about in the previous video. So knowing what the paramesonephric ducts turn into, and knowing that it is the ovaries that are going to provide support for things like the breast and body hair. And lastly, we talked about DES exposure as a high yield teratogenic effect on our newborns that are going to be female.